Thank you so much, Dr. Amit. First of all, I would like to thank AIOS and Dr. Amit for including me in this instruction course. Is my slide visible, Dr. Amit?
Yes, it is.
Yeah. So I'll be talking about clear lens extraction and peripheral iridotomy in angle closure disease. First of all, I have no financial interest in any of the equipment, procedure, or investigation shown in my presentation. To understand the management of angle closure, we have to first understand the pathogenesis of angle closure. The first event is usually a pupillary block, which leads to anterior bowing of the iris, and then crowding of the iris, which leads to a positional angle closure. And further, if we don't interrupt the process, it will lead to a synovial angle closure, and then episode of angle closure glaucoma. So to prevent this all to be happening, we can do a laser YAG peripheral iridotomy, which is a very safe and effective tool procedure to prevent abolish the pupillary block. So just we can create a peripheral iridotomy which can establish alternate pathway for the aqueous outflow. So that is established treatment for primary angle closure glaucoma, primary angle closure suspects in special cases, and also in the contralateral eyes of acute primary angle closure glaucoma. It's a safe and quick procedure, and it takes around 2-3 minutes after preparing the patient, and it's an outdated procedure, so it's very easy to perform. Although there's very less complications are seen very less, but there are transient rise of intraocular pressure. So in certain hyphema can be seen in certain condition. Sometimes patient may complain of dysphagia especially if the PI is done in the palpebral zone, and rarely it can produce aqueous misdirection syndrome and progression of cataract. Now, again, understanding the risk factors of primary angle closure. What are the risk factors actually causing the angle closure? In most of the cases, the lens bulk, which is increasing in size with the age of the patient, is occupying large area in the large volume inside the eye. So that is is a major cause in most of the cases. A shallow anterior chamber with area and volume, a thicker iris and anterior contour of the iris, or convexity of the iris, or curvature of the iris, and a high lens vault. Now, what is lens vault? Lens vault is the perpendicular distance of the anterior lens surface from to a line drawn artificially from the point connecting two scleral spur. So this is the distance called as lens vault. So with the aging of the patient and with the progression of cataract, this lens vault increases over the period of time, which causes the crowding of the angle. So remove the lens can depend the volume of the anterior chamber or depth. So as we can see in the OCT picture, if you remove the lens and put a 1 millimeter thick, a 4 millimeter thick lens, which is cataractus, getting replaced with a 1 millimeter thick acrylic lens, so large amount of volume is formed. So it also, apart from that, it also revolves the pupillary block, and also it inverts parietal iris mechanism. Also, additionally, in the bag implantation, the IOL causes traction of the trabecular meshwork, and that can open up the trabecular meshwork also. Apart from this, there are other mechanisms which also helps in angle closure glaucoma. Because of continuous flush of the fluid and this hydrostatic pressure, it can mechanically strip open the few of the synapses which is recently formed. It can flush the trabecular meshwork, so it can also help in removing the blockage. Because of the increased amount of prostaglandins, interleukins, necrosis factor, it can enhance the alternative pathway or UV scleral flow of the aqueous. So based on these studies, there are wide acceptance of lens-based surgery for the management of angle closure disease. However, a clear lens extraction still remains controversial in the absence of concrete evidence. So it doesn't give a license to do a clear lens extraction. Now, there are various studies who have compared the clear lens extraction versus conventional therapy. Now, this is a study by Tham and colleague, which they have compared the result of clear lens extraction versus trabeculectomy, and in 26 eyes they performed phacoemulsification and 24 eyes they performed a trab. And over a period of 24 months, they found that the IOP reduction was similar in both the groups. However, a trabeculectomy groups encountered more amount of complications. They also needed fewer drugs, but the complication was slightly more. So they emphasized that the trabeculectomy can be bypassed, and we can directly go ahead and do a cataract extraction in such patients. This is a study, Indian study by Tanuzada et al. They have performed this normal conventional iridotomy, and once the IOP was not controlled, after 8 weeks, they performed the clear lens extraction when the IOP was more than 25 millimeter of mercury after doing a YAG PI. And they have found that the IOP dropped from a mean of 27 millimeter of mercury to 13 millimeter of mercury, and also other parameters like angle opening distance becomes hugely increased from 102 to 0.31. So almost 3 times it is getting increased. So there is wide opening angle after the clear extraction. Major controversy arose after this publication by Lancet, which is effectiveness of early lens extraction for the treatment of primary angle closure, or EAGLE trial. So they advocated the role of clear lens extraction over the conventional therapy for the treatment of primary angle closure. They included 50 patients. They included 50 patients who are more than 50 years of age. It's a multi-centric randomized controlled trial done in five countries and more than 30 centers. They enrolled 419 patients, and out of which 155 has primary angle closure and 263 has primary angle glaucoma. So 208 patients were subjected to clear lens extraction, and 211 patients were subjected to standard care of doing a peripheral iridotomy and medically managing the case. And if the surgery is required, then further doing the surgery. What they have found that the mean IOP of 1 millimeter lower in the clear lens extraction group at the age of 3 millimeter as compared to the conventional therapy. Less patients in clear lens extraction group received any further treatment. Visual acuity was better in ETDRS chart, and they also had better contrast sensitivity and correction of refractive error. If you talk about visual field deterioration, there was no significant difference in the clear lens extraction group and the conventional therapy group. But this study has several limitations. First limitation is the sampling bias. So out of 805 patients enrolled for the study, the study was done only in 419 patients. So preferably the patients were selected seeing their IP levels and other things. The authors have also clubbed primary angle closure and primary angle closure glaucoma together, which is not because both of the diseases have different prognosis and different outcomes, so they cannot be clubbed together. Major drawback of this study is the gonioscopy data. They did not document proper gonioscopy in most of the patients, and also lens related changes like vault of the lens and intumescence of the cataract was not mentioned in the study, which is a very big limitation to the study. One of the positive findings that showed that the improvement in the quality of life was assessed by questionnaire like European Quality of Life 5-dimension index. Now this questionnaire is the subject of perception. Same question will be asked to me and some other person. They may feel different to a different situation. So it's a matter of perception. So there is a potential bias in the questionnaire and the results. And they have shown that it is very cost-effective way of managing the glaucoma. But again, the cost effectiveness is a matter of geographical location of the patient, cost of surgery in that location, whether the patient is insured by medical insurance or not, and also the role of government in supplying medicines and other procedures. So it's a multifactorial thing which cannot be generalized in different countries. Regression of the mean. Now, this is again a limitation of this study. Now, Chen and al. Have noted that a high IOP is the single most significant factor associated with a great IOP drop after phaco insufficiency. What is says? So, regression of mean is a statistical phenomenon. If you have a significantly high pre-op pressure, and after doing a procedure, the IOP drops, that signifies or that extrapolates that the procedure itself is a reason behind a significant drop in the pressure. So because of the high pre-op pressure and regression to the mean, the significantly lowered IOP mentioned in many of the reports, both EAGLE study and the study by Dada, they have the pre-op IOP more than 30 and more than 25. That is why the drop in IOP was very much significant. Just 2 minutes. Also, doing an phacoemulsification or cataract extraction in angle closure disease have multiple risk factors. They have shallow anterior chamber, they have a small papillary aperture, small pupil and flaccid iris. So there is huge risk in doing surgery in such patients. In this study, they have also documented the cases of posterior capsule rupture, vitreous loss, corneal edema. So visual acuity was deteriorated. So just imagine a situation, a patient coming with a vision of 6x6 with a high IOP, and we are doing a phacoemulsification. Remember, the study was done at the best center with best of the equipments and best of the surgeons. If an average surgeon does that, he might end up in complication, and the visual acuity may drop from 6x6 to less than that. So that can compromise the quality of life and also implicate a serious medical legal issues to the doctor also. So the actual flow chart should be, if in case of mild glaucoma with cataract, we should go ahead and do a cataract surgery. If patient has severe glaucoma with cataract, be done. Just and if the patient doesn't have cataract, we should do a trabeculectomy only. Phaco-trabeculectomy should be done in special cases only, where the anterior chamber depth is less than 2 mm, length thickness to axial sense, the ratio should be is less than 0.2 mm, or there is a microphakia and sagittal diameter is less than 6.4 mm. And also the special condition where we can consider early lens extraction, but not a clear lens extraction. So my summary is the conventional treatment of doing a PI and medical management is more scientific and safe. Early lens extraction should be tried in primary angular glaucoma with unfavorable outcome. Prudent counseling is a must, and laser iridotomy should be performed in all cases. We cannot bypass this step, and combined should be done in cases of severe glaucoma. Thank you so much.